numbers game. As I had mentioned earlier, it all depends on a very good preoperative workup, which is most important. And based on this workup, a good surgical plan should be devised, and then it is up to the surgeon's skill and knowledge and experience to execute this plan to perfection. A preoperative workup should start with a complete vision assessment and full cycloplegic refraction, especially in young children. Any amblyopia present should be managed accordingly, because presence of dense amblyopia may interfere with the long-term stability of the postoperative alignment. And prism bar cover test should be done in primary gaze, up gaze and down gaze, as well as lateral gazes to identify presence of any A or V patterns, and also lateral concomitants in case of intermittent strabismus. Restriction of movement should be noted, and in case of paralytic strabismus, primary and secondary deviation should be measured as well. Some important anatomical points that should be kept in mind: the distance between the insertion of the recti and the limbus, which varies between the rectus, and the anatomy of the anterior ciliary vessel should be kept in mind, because operating on more than 2 recti muscles may lead to anterior segment ischemia. Some other points: the sclera is thinnest just behind the insertion of the recti, and the muscle sheath should be preserved, especially posteriorly, to avoid fat prolapse, and the vortex vein anatomy should be kept in mind, and always it should be identified whenever possible to avoid inadvertent damage to the vortex veins, which may result in profuse bleeding. And some of the there are many various tables available in various textbooks, and more or less similar tables. This particular table suggested by Pratt Johnson is being widely followed in Arvind Eye Care system, and especially it holds true for previously unoperated horizontal recti muscle. Roughly up to 5 millimeters of recession or resection corrects around 2.5% diopters, and 6 to 7 millimeters of surgery will correct around 3, 8 to 9 will correct 4, and 10 will correct 5. And for example, to quote an example, to correct a 30% diopter of exotropia, we can plan a 6, if we plan a resection procedure, we can plan a 6 millimeters of lateral rectus recession followed by a 5 millimeter medial rectus resection, which will give around 30 to 32% diopters of correction. If the amount of deviation is less than 30, let's say 25 and 30, we can even plan a 6/4. Similarly, in previously unoperated vertical recti, each millimeter of correction corrects around 3% diopters of deviation. To know the lower and upper limits, in the case of medial rectus, the minimum correction, minimum amount of surgery that can be done is 2.5 millimeters, because less than that, because of the fibrosis of healing, it may nullify any expected muscle weakening, and more than 5.5 mm of recession or resection may not yield proper result, because more than 5.5 mm of recession will move the muscle beyond the arc of contact, and then it results in retraction effect rather than adduction. And whereas in resection, if you do a resection of more than 5.5 to 6 millimeters in a case of medial rectus, it results in loss of muscle belly, and hence results in leads to a myectomy sort of effect. For a lateral rectus, the minimum is 4 and the maximum is 8.5. These numbers are given for basic non-commitant strabismus, and these numbers can be changed in case of paralytic or restrictive strabismus. And similarly, for superior and inferior recti, the minimum and maximum is 2.5 and 5. Beyond 5 mm of inferior rectus recession can cause lower lid retraction and cosmetic widening of the palpebral fissure. And this surgical dosage table I have taken from Dr. Pradeep Sharma's textbook on strabismus, which I'm sure most of us would have read at some point of time in our career. It gives basic numbers, guidelines on basic numbers that can be done for both esotropia and exotropia, and as well as when doing surgery on a single eye or a single eye resection procedure, or a bilateral medial rectus or lateral rectus procedure. For example, a 30 prism diopters of exotropia, we can do a recess resect of 6/4 or a bilateral lateral rectus recession of 6 millimeters. And some situations where we may have to deviate from this normal plan when there are restriction of duction, as in the case of restrictive strabismus or even paralytic strabismus with contraction of muscles. When in young children on the table forced duction test, it's always a good habit to do a forced duction test on the table before starting the surgery. In young children, when we identify some restrictions, maybe we may have to deviate from the normal plan. and presence of lateral incomitance in intermittent strabismus and while tackling obliques. Normally, inferior oblique surgery, bilateral inferior oblique surgery doesn't have any influence on the horizontal muscle surgery, whereas a bilateral superior oblique surgery can cause around 8 to 10% diopters of ESO deviation, and this should be kept in mind when operating on bilateral superior obliques along with horizontal recti. When the amount of deviation is the same for distance as well as near, it is better I prefer to do a resection of the same eye. Whereas symmetrical surgery on the medial recti produces a greater result at near than distance, whereas a symmetrical surgery on lateral recti can produce more effect at distance than near. Some of the indications for surgery on oblique muscles, some of the common indications include superior oblique palsy, Brown syndrome, associated vertical deviation. These are indications when they may not be associated with horizontal deviation, or when horizontal deviation associated with A or V pattern. And obliques can be combined with horizontal recti because they do not contribute to the anterior segment circulation. Even a 3 muscle surgery with 2 recti and 1 oblique doesn't cause anterior segment ischemia. Any oblique overaction of 2 plus or more, if it is associated with A or V pattern, should be tackled. The commonest surgeries for inferior oblique muscle is the Parks or the Fink's recession for 2 plus, and if it is more than 3 or 4 plus overaction causing severe V pattern, a graded recession or myectomy can be considered. And when inferior oblique overaction is associated with DVD, an inferior oblique anterior positioning method should be considered. Some of the superior oblique weakening procedures include the tenotomy, the posterior tenectomy, which are used in tackling A pattern associated with superior oblique overaction. A silicon tendon expander or a split tendon lengthening are considered in case of Brown syndrome. Even a chicken suture can be done. And superior oblique strengthening procedures like a tuck can be considered in superior oblique paralysis. And some of the dilemmas when we get a small angle strabismus, whether we can do a single muscle surgery or resection procedure. It is better to avoid large recessions of a single muscle as it may cause incomitance in the field of action of the operated muscle. For example, in case of 25% diopters of exotropia, we can do a 5x5 resection or a single muscle lateral rectus recession of 7.5 or 8, even 8.5, depending upon the patient. Literature search have been favoring single muscle surgery in case of small angle strabismus. Even in people have achieved good results even in up to 30% diopters of esotropia with single muscle recessions. It is always a good habit to measure the original insertion of the muscle from the limbus, especially in case of infants and small eyes, and it is especially helpful when we are planning for resurgeries and all doubtful cases. An adjustable suture technique is always a good armor in the strabismologist tools, especially helpful in case of resurgeries, small angle strabismus, and complicated cases like the thyroid eye diseases and restrictive strabismus. So to conclude, these numbers are only guidelines, and based on one's experience, each should have their own numbers, which will, I'm sure, definitely it will change over a period of years. And again, to reinforce a good and accurate preoperative workup with a good surgical technique will yield good results. Thank you.